Good afternoon, everyone, and welcome to Health Coverage for All. What does that mean, and what are the implications? My name is John Graby, and I direct the Warren B. Rudman Center for Justice, Leadership, and Public Service at the University of New Hampshire Franklin Pierce School of Law. I'm so pleased that the Rudman Center has joined with our frequent collaborators, the Concord Coalition and the UNH Franklin Pierce School of Law's Institute for Health Policy and Practice to present today's webinar. I'd like to acknowledge and thank the New Hampshire Medical Society and Granite State Progress, which have partnered with us in planning and providing this program. I'd also like to express special thanks to the Peter G. Peterson Foundation and to the Endowment for Health, which have provided generous support for this event. I am now pleased to introduce today's moderators, both of whom, I am proud to say, serve on the Rudman Center's Board of Advisors. Robert Bixby is the Executive Director of the Concord Coalition, a nonpartisan organization that encourages fiscal responsibility and helps to educate the public about the federal budget. Bob has been with the Concord Coalition since 1992, serving in a variety of roles. Before joining the organization, Bob practiced law and served as the Chief Staff Attorney of the Court of Appeals of Virginia. Lucy Hodder is a professor of law and directs the Health Law and Policy program for UNH's College of Health and Human Services Institute for Health Policy and Practice. Lucy previously served as legal counsel and senior healthcare policy director to New Hampshire Governor, now US Senator Maggie Hassan. Prior to her government service, Lucy chaired the healthcare practice group at the New Hampshire law firm of Rath, Young, and Pignatelli. Lucy?
Thank you so much, John, and welcome everybody. We wish we could see you all. We are going to take on this topic and share with you some meaningful information that should begin a larger conversation. I want to give you a little bit of an overview of how we're going to do this in the time we have together. We have a chat box, but it's disabled. You will be able to see what we chat to you. Your way to communicate with us should be through the Q&A thing on the bottom of your screen. Submit a question, please. The moderators will pick up the questions that you submit in the Q&A and ask them to the panelists. We will also be saving the Q&A in order to be meaningfully respond beyond this webinar. So type your question in the Q&A, please, at any time during the presentation. There will be no raised hand feature in this. So thank you very much for that. If you want to tweet, we have a hashtag Health Coverage for All, and please share what we're talking with you about today. This webinar is also being live streamed. I just want to quickly thank a number of people who've helped us, Chase Hageman and Tyler Sweeney from Concord Coalition, as well as a whole series of staffers at our various institutions. Thank you for your help today. Why is health insurance for all on the minds of so many right now? Where will the conversation about health coverage for all take us in the next year? And how will we pay for the rising costs of care due to COVID-19? These are pressing questions that we have been hearing from all of you on the ground, in webinars, in conversations today, and we want to talk about them. Next slide. So what does health coverage for all really mean? We're having this conversation at a time when public health pandemic has been declared at every level of our political, regulatory, economic, and social structures. Never have we been individually or collectively so engaged in our health and well-being and dependent on our families, friends, and communities around our health and healthcare. We are living health risk and financial risk right now. Over half of us adults say that the worst of the COVID-19 crisis is yet to come. And we are also living in the context of the death of George Floyd and the recognition that our healthcare system has disparate impacts. Black people constitute 13% of the US population, but make up 23% of COVID-19 deaths, according to the CDC. Rates of disease and risk disproportionately impact women and racial minorities in New Hampshire. We have unprecedented unemployment in a system dependent on employer-sponsored coverage. So healthcare, access to it, whether or not it works and how we pay for it is on all of our minds. Coverage for all. The terminology is very confusing. What do we mean by coverage for all? What we mean by coverage for all may actually reflect how we feel about the topic. So 63% of the public have a positive opinion of universal healthcare coverage. That's where everybody has health insurance coverage so that they don't bear the financial risk of a healthcare event. Medicare for all, 63% have a positive reaction to Medicare for all. Medicare for all is expanding a government program that exists for the elderly and the disabled to more people. People do not have as positive a view of socialized medicine, however you define that, or a single payer health insurance system where you have one payer funded by the government administer our health plan. So it really depends on how we define the topic to what the public's opinion is about it. And we're going to talk about that today. Most of us support the federal government doing something to help pay for our health insurance coverage, 74% of us. About half of adults favor both Medicare for all and the public option, which is interesting because if you take out one or the other, people have different views, but favoring both, 48%. What people like about both the public option and Medicare for all is they really want a choice. They want to have a choice of how they're covered for care. Next slide. So how are New Hampshire residents covered? This is important when we talk about healthcare coverage and how we fund it. We want to know who funds our healthcare, how is it funded? What we've learned during the COVID crisis is everybody has slightly different rules, so it's never easy to organize our outcomes. 56% of us have employer-sponsored coverage, about 14% Medicare, and about 10, almost 11% Medicaid, and that's climbing. Next slide. What have we seen pre-COVID in our health insurance, which is part of why we're having the conversation about what we want in the future? Premiums are, in New Hampshire, the highest in the region for large groups and consistently higher than the US average. Private payer prices in New Hampshire are significantly higher than Medicare and verging on being an outlier in states. Out-of-pocket costs are growing faster than wages. And between 2011 and 2016, the average deductible associated with employer coverage rose 11.8%. We are scared of what kind of financial risk we are subject to around our healthcare. Next slide. So we're going to take a quick poll today to ask you, what method do you support to achieve health insurance coverage for all? Medicare for all, Expanded Affordable Care Act, government-run public option, or free market competition and transparency-based method? Okay. So these are our results. 38% of you, Medicare for all, 26% of you, Expanded Affordable Care Act, 21% government-run public option, and 15% free market competition and transparency-based methods. That's where we fall today. So I am thrilled to be introducing our panelists today. We have Margarita George, who is the Executive Director of Healthcare for America Now. Healthcare for America Now is the national grassroots coalition that ran a $60 million 5.5-year campaign from 2008 to 2013 to pass, protect, and promote the Affordable Care Act and protect Medicare and Medicaid. Ms. George will discuss policy proposals and financing to address today's gaps in the healthcare coverage. We're going to be leading off today with Chuck Blahos. Dr. Blahos is the Fish and Lillian Smith Chair and Senior Research Strategist at the Mercatus Center at George Mason University. Dr. Blahos specializes in domestic economic policy and retirement security with an emphasis on Social Security, as well as federal fiscal policy, entitlements, and healthcare programs. And he's going to be offering a fiscal perspective on the conversation of healthcare for all. And Dr. Patrick Ho is the president of the New Hampshire Psychiatric Society. He is also currently the chief resident in psychiatry at Dartmouth-Hitchcock and a clinical instructor in psychiatry at the Geisel School of Medicine at Dartmouth. He will share with us his perspective as a provider on healthcare for all, with a particular emphasis on patients with mental illness. So thank you so much. I'm going to hand it over now to Dr. Chuck Blahos.
Thank you so much for having me, and thank you for the very nice introduction. As was stated earlier, I'm bringing a specific perspective to this discussion of coverage for all. My analysis that I'll be talking about today was a study of one specific approach of the many approaches to providing coverage for all, and that was the so-called Medicare for All legislation that was introduced by Senator Sanders in 2017, analysis that I published about a year and a half ago. Just going to the next slide, I would just preface my remarks by saying, again, I'm not, as an analyst, able to answer these very difficult questions in value judgments as to whether Medicare for All is a good policy or a bad policy. All my analysis can speak to are sort of the quantitative effects. I can provide the analysis and the data and give a sense of what trade-offs are involved, but obviously the subjective value judgments are something that other people have to make. My study found that there was a lower bound on costs for a Medicare for All type system, that basically if everything works as we might hope and expect with respect to cost containment, the least such a system could cost is about $32.6 trillion in additional federal costs over the first 10 years. More likely, for various reasons that I'll discuss today, total costs would be somewhat higher, somewhere between the range of $32 and $39 trillion over the first 10 years, and that's additional federal costs above and beyond current spending. It's very difficult for to wrap our minds around such mind-numbingly large numbers. So one data point that I put in the study to help try to help people understand this is that that is something larger than we would be able to finance even if we were to double all currently projected federal income, individual income, and corporate income taxes. So if you take your current tax bill, your current income tax bill, and double it and add a little bit to that, that's probably the least that this could cost, or the least you'd be responsible for financing. More likely it would be somewhat more. Proceeding on, I want to say a little bit about the specific proposal, the specific approach that I studied. This is a proposal for a universal federal health insurance program. It would provide first dollar coverage of basically all health services. People wouldn't face deductibles, they wouldn't face co-payments. In that respect, it's very different from a lot of the insurance that many of us carry today. It's called Medicare for All in the popular vernacular, but that's really a misnomer because it's really not Medicare. It's a very different program from Medicare. The benefits would be different, the benefits would be more generous, the coverage would be more generous, and everyone would be moved into it, including current seniors. So again, it's often called Medicare for All, but it's a very different type of system. The particular version of the legislation that I studied did not have a long-term care benefit. The only reason I'm pointing that out is that most proposals, including Senator Sanders' own proposal introduced since then, they do have long-term care benefits. And that, if you adjust for that, you would have to add about $3, $4, $5 trillion to the numbers that I'm citing today. Now, my next slide is basically the meat of my presentation. And I put this in here to help people just basically understand how one constructs sort of a lower bound estimate for how much a Medicare for All type system would cost. Basically, this shows the major factors that would bear upon a cost estimate for a single year, 2022. Under current projections, or at least the projections at the time my study was performed, we'd be looking to spend about $4.5 trillion as a nation on health-related expenses. That would go up to a first approximation under Medicare for All type system for the simple reason that when you move people from being uninsured to being insured, they tend to use more health services. And obviously that's intentional. That's part of the reason for the policy, is to make sure that people who do not currently have health insurance coverage are able to access health services. But that does increase the total amount of services we utilize. But it wouldn't just be the currently uninsured who would use more health care under Medicare for All. It would be most of the rest of us as well. the reason for that is that when insurance covers the first dollar of your health expenses, you tend to utilize more. And this is unsurprising. If you go to the doctor and the doctor says you need a service, you need a drug, you need a procedure, and if your insurance covers all of it, you're much more likely to receive it, much more likely to utilize it. If, on the other hand, you owe a substantial payment out of pocket, you're more likely to undertake something of a personal cost-benefit analysis as to how much you're willing to pay. Again, putting the value judgments aside, obviously, this results in people seeking, demanding, and utilizing more health services. So against these cost increases, what most Medicare for All proposals do is they try to save money in other ways, primarily by cutting payments to health providers, by paying less for drug prices, and by saving money on administrative costs. Now, with respect to the provider payment issue, this is a graph that gives a sense of the magnitudes of what we might be talking about. When I analyzed the Sanders bill, that bill and a number of other bills, it contained language indicating that there would be a Medicare-style rate-setting process. Now, this doesn't necessarily mean that health providers would all be paid at Medicare rates. However, that's how we form our lower bound estimate on how much a system might cost, because Medicare payment rates are much, much lower than private insurance rates. As this graph shows, it's about 40% lower for inpatient hospital services. The gap is even bigger for outpatient services. For physician payments, the gap is somewhat similar. It's a little bit less in the near term, a little bit more in the long term. But obviously, if we were to right out of the gate cut payments to health providers by this amount, about 40% for everything that is currently covered by private insurance, that would be a very dramatic reduction in costs relative to a scenario in which we didn't have cuts of that magnitude. Now, going to the next slide, I would just review some of the questions that arise from this, which is, the first thing we have to ask is, what do we think the federal government would actually do? There's no real federal historical precedent for cutting payments to providers this dramatically right out of the gate in any policy. There have been various attempts over the years to try to slowly and gradually ratchet down payments to providers, but nothing on the order of magnitude of a 40% reduction in payments for treatments now covered by private insurance. Historically, when the federal government has tried to ratchet down payments to providers, it's tried to do so more gradually. Sometimes those cost savings have held, sometimes they have not. But obviously, if we were to pay significantly more than Medicare rates, if we didn't do those 40% reductions, then the cost estimate for a Medicare for All system would be substantially higher. We have a similar set of issues with respect to drug prices. Would we have a sudden and dramatic reduction in the amounts we pay for drugs or not? There's a lot of reasons to believe historically that we probably would not, but the lower bound estimate that I've produced assumes a very dramatic and sudden reduction in payments to providers and for prescription drugs. Now, this also unleashes another set of questions, which is, what happens if we're increasing the demand for health services at the same time that we're very sharply cutting payments to providers? Would there be issues for supply and access to health services? And again, we don't know the answers to those questions, but if we were not willing to cut payments to providers, then the cost estimates would be considerably higher than my lower bound estimate. Finally, on this slide, let me just note that there probably would be substantial savings in administrative costs for a number of reasons. Medicare for All would have advantage of various economies of scale. The federal government has certain revenue collection advantages relative to the private sector, and wouldn't face some of the expenses of the private sector. We have to be a little bit careful, though, because there is a limit to how much we could save on administrative costs. Occasionally you see somewhat exaggerated estimates for how much we can actually save on administrative costs under a Medicare for All type system. We have to remember that it's unlikely we could actually get administrative cost rates quite as low under Medicare for All as they are under current Medicare, for the simple reason that Medicare serves a senior population that has much higher per capita health spending than the general population. So we wouldn't be able to have administrative cost rates in a system like this unless per capita administrative spending was a lot lower than it is in current Medicare. Now, the last few slides that I'll be quickly going through, this slide is just to give a sense of what's the general magnitude of the cost of Medicare for All relative to things the government currently spends money on. On the left side of this graph, you see bars that look very, very small. And that's everything we're spending on defense, everything we're spending on non-defense discretionary appropriations, everything we're spending on all current appropriations combined, those all look quite small in this graph relative to the size of Medicare for All, which would be several times larger than any of those entire categories of federal spending. And the next slide simply notes that if you don't like my particular analysis, the bad news is that most analyses pretty much come out in the same place. This has been studied by a wide variety of experts and institutions. And the specific estimates really depend on particular assumptions for provider payment rates and variables like that. But if you push and pull on those estimates and equalize them between studies, most studies come up with pretty much the same numbers. So there is a general consensus as to how much this would cost. Finally, let me just address a couple of questions that sometimes come up. Sometimes you hear people say, well, I understand that this would cost the federal government a lot of money, but wouldn't that be okay because we're already paying for all this in other ways anyway? Unfortunately, that's not the case. The act of going from private sector financing of healthcare to federal financing of healthcare is not a trivial change. There would be dramatic economic implications of that change. The first question would be, can the government find a way to finance it, and how does it choose to finance it? And so far, no one has come up with a proposal for financing the entire cost of Medicare for All, but the mechanisms that people have talked about have generally involved taxes that are proportional to income and the like, that would have very dramatic effects on the size of the economy, would make our economy somewhat smaller, would make us somewhat poorer on average relative to how we now pay for healthcare. So that's not a detail we can simply gloss over. And finally, sometimes you will hear it said that, well, yes, this would increase federal costs, but it would decrease national spending on healthcare. Again, that's not what most analyses find. My lower bound estimate would show a very slight deceleration in the growth of national health spending. But again, that was the lower bound estimate. Most of the range of my cost estimates, including the more likely ones, show a somewhat of an increase in national health spending under Medicare for All. Most of the other studies do as well. So unfortunately, whether we're looking at the national perspective and especially the federal perspective, we're probably looking at increased spending. With that, I'll just wrap up and say, again, thank you for including me. And this is just one specific analysis of one particular approach, and I look forward to hearing about the others.
Great, thank you. And it was fantastic to hear about your analysis, Dr. Blahouse. I'm very pleased to be here today, so thank you for having me. I'm really glad to be able to present the perspective of those who work on the front lines, as well as our patients. So let me just first talk about the needs that patients and healthcare providers are communicating. And many of those needs fall into, first and foremost, the bucket of providing the right patient, the right care at the right time. So could a new system, instead of investing so heavily in treating the downstream consequences of chronic disease, could a new system emphasize prevention, especially in rural places like New Hampshire, where healthcare resources are not as plentiful? We can avoid costlier care that occurs when patients are unable to afford necessary medications, or when they feel that they should ration care and not seek care until their condition worsens, because this is an unfortunate reality of practicing medicine in a place like rural New Hampshire, and also many other rural parts of the country. And from a systems of care perspective, could we shift towards a regionalized model of healthcare where primary care is the focal point? For those who work in and around healthcare, it is our job to help people. And frankly, if everyone were to have coverage, healthcare coverage, then this would be a very exciting prospect, because this would make our job easier. However, operationalizing something like this would, of course, mean that we would run up against some barriers. For instance, medical schools, for the most part, do not provide comprehensive education on the topics of healthcare finance or behavioral economics, and these are very difficult topics to understand, of course. So I'm glad that our discussion today is couched in terms of coverage for all, because as Lucy and Dr. Blahouse had mentioned, then many people talk about this in terms of Medicare for all, when in reality, Medicare is a very difficult system to navigate for both patients and providers. So a major concern would be ensuring that a system of insurance coverage would be easier to navigate. Another concern is maintaining high quality of care. In determining the cost of healthcare, we have to consider not just the price of care, but also utilization and quality. So how can we maintain and improve the quality of care that we deliver under a different system? And how can we incentivize that? Finally, in resource poor and rural areas like many parts of our state, wait times can be very long, as Dr. Blau said, alluded to. This is especially true for mental health care and those seeking mental health care in New Hampshire. So one question or concern is, would coverage for all lead to the phenomenon of supply-sensitive care, where care is utilized because it is available, thus further tying up valuable and sparse resources? So lastly, I just wanted to speak specifically about mental health care, which is the field of medicine that I mostly work in. COVID-19 has obviously forced all of healthcare into a paradigm shift, and mental health care is no different. The wider availability of telehealth capabilities and rolled back restrictions and billing for them has been a great tool for continuing to provide high quality mental health care, even during a pandemic. So one big concern is continuing to provide mental health care via telehealth, although it obviously is not a perfect system and requires a broadband connection, which is something that not all patients have the luxury of having. Having telehealth care available is certainly preferable to not having it available. Another concern from a mental health perspective would be how would parity be addressed in such a system? In other words, will it still be more difficult to get reimbursed for providing mental health care than it is for other types of health care? And will our patients have to jump through more hoops to get medications for depression covered than they might to get medications for conditions such as diabetes covered? And of course, when many people have insurance that is tied to employment, this pandemic has caused many people to lose that employment, and it also has caused mental health needs to increase at the same time. So COVID-19 has certainly tested the healthcare apparatus's ability to withstand such a pandemic, and the hope would be that a new system would build upon these lessons that we're learning in the hard way. So overall, I think healthcare for all allows us to shift towards a population health approach and ultimately keep everybody healthier. And the bottom line is that it would remove one obstacle from healthcare access that is very difficult for many people to overcome. And even though that is not the only barrier access that people face, then that is certainly a significant one. But it also, of course, would not be completely straightforward to implement. So thank you again for having me.
Thank you so much, Dr. Ho. And now we're going to transition to Margarita George.
Hi, everybody. It's great to be on this panel, and I so much appreciate the comments of the previous two speakers because they set up perfectly for what I would like to talk about, which is directly related to some of the questions that were raised on the last two presentations. And I don't know if somebody else is going to advance the slides or we're just keeping up this slide. So just a couple of sort of overall points. COVID, which is sort of the biggest paradigm that we're looking at in the healthcare conversation right now at the national level, is going to really transform the healthcare debate in a lot of critical ways. But I do want to go back to what Lucy said at the beginning of the presentation, which is the way we gauge what the public supports in terms of changes to healthcare policy has a lot to do with the language that we use. In the years that I've worked on healthcare here at the national level, about a dozen years, the foremost thing that we have learned about healthcare policy and proposed changes to the system is that people pretty much initially oppose any change to the system. People are terrified about the healthcare system changing because there is so much anxiety that people experience around being able to access and afford healthcare. Years ago, back in 2008, when HCAN was created and we were looking at passage of the Affordable Care Act before it was the Affordable Care Act, we talked about this notion of the public option. And one thing that was central in the debate to healthcare is, what is the role of government? What is the role of government in the provision of healthcare and the provision of direct services and employing a workforce? And what is the role of healthcare in regulating cost and profit? And when we thought about the terminology around public option, I think we were thinking a lot about evoking this idea around role of government and government taking on greater responsibility for guaranteeing that everybody could afford coverage. But what we found over the years is exactly what Lucy said, which is that the compelling part of that language is really around choice, and that Americans tend to interact with healthcare often as consumers, not just as patients. And so that's really critically important to remember as we're moving toward 2021, where we could have big changes at the federal level that could or could not open up opportunities for significant changes to the system. One fascinating thing about the COVID epidemic and what is happening even with the current relief packages that are being debated right now is that the healthcare debate is changing. For most of the time that I have worked on healthcare, the debate has largely been around costs. Right? The healthcare debate in the United States is a debate about affordability and cost. It's largely not a debate about public health. And so COVID has tremendous opportunity to insert and infuse the debate with some larger concepts around public health that might get us to an analysis that elevates issues like social determinants of health, health disparities, chronic care, all kinds of issues that we really don't talk much about, especially not in sort of the politics of healthcare. Let's move to the next slide. So COVID and healthcare, I don't have to tell you all, huge new burdens in the healthcare system. Medicaid, there's no additional funding for Medicaid in the relief package that's being debated right now, but Medicaid is an essential program and is going to bear a lot of the brunt of what is happening with COVID, in addition to, obviously hospitals and private providers. Here we are in a moment. 5 million people have lost their employer-sponsored coverage. Urban Institute predicts that it could be up to 27 million. It's really calling into question this model of whether an employer-sponsored system is where we want to be, given that this is probably not the last crisis that we're going to be facing, where people's healthcare is going to be at risk. The Affordable Care Act covers about 11 to 13% of the population. It was a big achievement as much for what it did in terms of regulating health coverage in the private sector as for the expansion of the public program, right, of Medicaid. But one thing that we should give us pause and that we're really worried about is that the Affordable Care Act, including all of the great provisions that we talk about all the time, like no-cost preventative care and protection for people with pre-existing conditions and closing of the donut hole, all kinds of things in the law, is at risk right now because the law is being challenged at the Supreme Court once again. It's going to go to the Supreme Court in the fall. It's really unclear what's going to happen in the current court. And so the fate of the Affordable Care Act, which I'll just say coincides with the upcoming election, during a stretch of time, the last 4 or 5 years, where healthcare has been the central issue in elections, is going to create, I don't know what it's going to create. It's going to create a very interesting environment for the healthcare debate over the next year or two. So the Supreme Court challenge, I've just listed a few things on this slide. Folks probably know all of the different statistics about what is at stake for people. Most people actually have no idea, and we work with a lot of grassroots groups that do direct outreach on Affordable Care Act enrollment, a lot of work on Medicaid. And especially right now, we're doing a lot of work to see what is possible in terms of expanding different features, increasing subsidies to cover people that have lost coverage because of COVID. And what we are finding is that actually mostly folks don't know that the Affordable Care Act is under attack at the Supreme Court. Mostly people also don't know about the many administrative changes that have been made to the law over the last 3.5 years. One thing that I will say is that I really appreciate the conversation earlier in the presentations about the role of revenue and how critically important revenue is. Fundamentally, no matter where public support is for various different proposals, the speaker before me, I thought, said this really well. We can't sort of treat cost as a detail that people won't question, won't interrogate, and won't care about. People will care about it a lot, and the people that will care about it the most are lawmakers. So the central question is, what would the federal government do? But the real question isn't just what would the federal government do, but what are politicians going to do? because we are in a very sensitive moment about revenue right now, given the economic recession and the huge cost of COVID, both in a public health way and also in a revenue way. So the real question is, you know, what are politicians going to do over the coming year? And it's really an unknown, but I think the good news about that question is that constituents actually have a fair amount of influence over what legislators are going to do at the state and at the federal level. Coverage for all has never been a more timely topic than it is right now, when every single day the number of unemployment claims is rising and people are going without coverage, when state and local governments are facing huge budget shortfalls that are going to force cuts in public services, healthcare workforces, you name it. So this is a really good time to be exploring this question, because COVID has exposed a lot of the challenges. Just a couple of things that I want to flag for people that are sort of contemplating and trying to plan. What do we think the debate at the national level is going to be around healthcare over the coming year? I would say a couple of key factors to consider. Obviously, the political makeup of Congress, right? We are in a gridlock right now. There's so much polarization. There are a few areas, though, where I think we actually could overcome polarization to pass some good policy. The COVID conditions, particularly the impact on revenue, is going to be a huge, huge factor. Keep in mind that next year, what we would expect to see in Congress is massive spending on stimulus to get us out of this recession, right? And if that happens, then massive spending on things like, you know, infrastructure and jobs might not translate into expansions of healthcare. They could, but there would need to be a deliberate approach. Really important factor is the Trump tax law and the way that tax law has limited revenue further, and whether or not we could generate new revenue. So I would totally agree with the previous speaker that if you're going to talk about a massive expansion of coverage, you have to talk about new revenue. You're not going to do it with the existing revenue. Another thing to keep in mind that's really important, we always underestimate the impact of this, but it's critical, is we don't just have to think about what is going to be the different political makeup in 2021, because it's a big election year this year. But most politicians, once they take over, what they're really thinking about, in addition to the policy they're going to pass, is the midterm elections. And we have seen the seesaw back and forth in Congress around healthcare and the midterm elections and how it has shifted party control. That is really important if you are an organization or an individual that does a lot of lobbying of lawmakers, to understand that on your lawmaker's mind is the policy and what's good for constituents, but it's also what is going to be the fate of different politicians during the midterm.
MJ, some parting words so we can move to questions would be wonderful.
Great. The key thing that I would watch is the prescription drug reform debate. It is by far the sexiest healthcare debate right now. And it is the one place where a lot of people can envision some type of bipartisan compromise to lower prices on prescription drugs. And of course, there's varying opinions on how structural the reforms are going to be. But you can see, if you're following the news, it's the hot ticket item that everybody wants to talk about. And it's going to be the area of greatest opportunity for next year. I'll stop there.
Okay, thank you so much to our speakers. Audience, we have another poll for you. So these questions are: has the COVID-19 pandemic made you more likely to support government intervention to achieve health insurance coverage for all? Yes or no? Should cost to taxpayers and economic impact be significant considerations in achieving health insurance coverage for all? What's wonderful is we have so many people on this call that we're going to get a really great indicator. Okay, so 82% say that the COVID pandemic has made you more likely to support government intervention to achieve health insurance. And 86% should cost to taxpayers and economic impact be significant considerations. So we are thinking hard about government intervention, but we want to be really careful about the tax consequences. So thank you for that poll. Bob, I'm going to turn it over to you to ask some questions of our panelists.
Okay, well, I thank you, Lucy. Thank you for spearheading this conference. and thank the audience and the panelists. That is an interesting poll result that we just had, which is actually kind of reassuring, which is to a budget person such as me or the Concord Coalition, that if we are going to move to a broader coverage for all type of model, that people are still concerned that we do need to worry about what the cost would be. So the search for a more efficient healthcare system would continue, and I think we'd have to do that. So I'm going to ask one question of each of the panelists, and then we'll take your questions, which are piling up in the Q&A session. Let me start with Dr. Blahaus. One of the things that you mentioned in your presentation, and I wanted to go back to it a bit because it's a pretty stunning figure. I read the Medicare trustees reports every year, and because of certain actions that Congress has taken about reimbursement rates in the future, the Medicare trustees and the chief actuary of Medicare actually warns every year, basically says, don't believe the numbers in this report. I mean, they're probably unachievable because they're assuming a level of savings through the reimbursement rates to providers that would be so much below private sector reimbursements that it probably is unsustainable. Could you comment a little bit about that? I mean, because I don't think it gets enough attention that in saying you're going to stick to Medicare rates, that sounds very reasonable, and yet the trustees are telling us the Medicare rates that we're publishing are probably not reasonable.
Well, that's a very good question, actually. And the graph that I showed in my presentation was literally copied and pasted from the CMS actuary's memo discussing this very issue. And as it shows, there is a wedge in payment rates or gap in payment rates between private insurance rates and Medicare rates. And under current law, per the terms of the Affordable Care Act, that gap is going to get bigger over time because the Affordable Care Act contained some gradual but ambitious efforts to slow the growth of payments to providers. Now, when the law was first enacted, the actuaries and the trustees raised the concern, what happens if these don't hold? What happens if these don't hold? Then Medicare costs are going to be substantially higher than we're showing in the main trustees report. Now, the good news is they're holding so far. The good news is they're holding so far. So far, so good. If they didn't hold, and if they don't hold going forward, Medicare itself is going to face an even sooner solvency crunch than it already is. Now, under the last trustees report, Medicare hospital insurance was projected to be insolvent in 2026. Because of the COVID crisis and its depressive effect on payroll tax revenues, that could move forward to 2025 or 2024. So from a Medicare financing perspective, we should be hoping that the Affordable Care Act's provider payment restraints do hold, because if they don't hold, we're in even deeper trouble with respect to financing Medicare. But this also cuts to the larger point, which is that we still haven't figured out how we're going to finance current Medicare, let alone Medicare for all. We've got just a couple years left of solvency in the current Medicare program. Congress hasn't dealt with that yet. We still have to answer those questions.
So Dr. Ho, I have a question that, and if it's a stupid question, just tell me it's a stupid question and move on. But you are practicing in a rural area, or at least sensitive to practicing in a rural area. So if we move to a system of coverage for all, might that lead to an access problem, or over demand and under supply of areas that have that now? And could that be a problem that would have to be addressed, and any suggestions on how that might be addressed?
Certainly, and Bob, that's a fantastic question too. And one thing that I would point to is the results of the RAND health insurance experiment that happened in the 80s as well, which did, of course, show that when everybody has insurance coverage, then initially, of course, then you do see that there is a bump in terms of people utilizing healthcare coverage. And that's something that we would, of course, have to consider. And in my remarks, I mentioned using a regionalized focus on healthcare, which would renew the focus on primary care. And what we know about disease is that disease is multifactorial. Our current system tends to be rather siloed in which providers and different disciplines work within their own silos without much of the team approach. So when we think about quality healthcare, then we think about needing there to be greater collaboration between disciplines and between medical specialties as well. So in a regionalized approach rather than a dispersed approach where patients can enter the healthcare system at any level without the need for a primary care physician, then that does increase the siloed approach that we do take to medicine, and also increases the utilization of costlier care. So one suggestion in a new system might be making medicine more collaborative through a more regionalized approach in which patients can see their primary care physicians who then collaborate with other specialties, other medical specialties, as well as other disciplines within the field, because this could solve some of the access problems by innovating the ways in which we deliver care.
Thanks. Margarita had a kind of a broad question of cost control strategies while still promoting access and quality. Somehow we have to do all three. And, you know, one of the strategies that was in the Affordable Care Act that has now been repealed was the so-called Cadillac tax, which was supposed to be to encourage savings by imposing a tax on so-called high-cost plans. And, you know, that was a major part of the budgetary savings that was supposed to pay for the expanded costs. That's now been repealed. And so, you know, from a budgetary matter, it means more costs than were originally estimated. But I think more importantly, it was the loss of the incentive for cost savings in employer-provided insurance. And I'm wondering if you could talk about what the future might hold in terms of reform. Should something replace that, or would there be mechanisms in a coverage for all that would make up that loss?
Well, I mean, I think that both routes are an option, right? Certainly you could, you know, replace something like a Cadillac tax. I mean, we were never, you know, the Cadillac tax, which is essentially a tax on very comprehensive plans, I think actually is the wrong direction to go. And I think if you're looking for cost savings, the best way to achieve cost savings is actually to see if you can limit more things on the profit side, right? So another reason that groups are looking, for instance, at prescription drug reform and figuring out how to lower costs on prescription drugs is because we see that the price of prescription drugs, especially high launch prices on new drugs for chronic illness like cancers and others, are increasingly driving the cost of premiums. And so what we see, you know, throughout the system is tons of cost shifting. And the question is really, how do we, you know, capture some of that? How do we create some savings out of that cost shifting? We're not going to do it, though, unless we are willing to directly regulate profit. The other area, of course, is reimbursement rates. And I think the reimbursement rates conversation is a very difficult conversation to have with people. And frankly, neither Democrats nor Republicans want to talk about cutting reimbursement rates. It's a very sensitive conversation, but I don't think that there's any way that we're going to get to larger cost savings without tackling the very difficult issue of reimbursement rates. And we're seeing it right now in things like the surprise medical bills debate, right? Where people have coverage and they're still going to the hospital and incurring massive medical bills because the anesthesiologist that treated them when they came into the emergency room wasn't part of their network. So it's a very complicated problem, but I would sort of be in favor of those types of reforms to limit cost in the system, as opposed to saying to people who have comprehensive plans, well, you should pay more for your plan.
Thank you. Lucy, you've been looking at some of the questions that are accumulating in the Q&A box. You want to lead off?
Yes, and we have some great questions. I'm going to try and do rapid questions to each one of you because there are just a lot of questions, Dr. Blauhaus, Chuck, about costs. So isn't a lot of our costs going into profits to insurance companies, administrative costs to physicians for administering the multiple different plans? Just look at how much it costs to get all the regulations and all the different health plans done just to allow for telehealth. So the questions that we're seeing isn't there a lot of cost in our system that if we had a more streamlined single payer, we could control better? Why are foreign countries able to do it at a quarter of the price that we are? We're spending a lot. Won't it help us save, even if there's a high price tag?
Well, I would say there's multiple questions there. I mean, certainly the one question is about administrative costs, and the question is, are administrative costs too high, and would Medicare for All lower those administrative costs? I would say yes and yes. My study assumes that the majority of our current administrative costs would be eliminated in a Medicare for All type of system. However, even if you completely eliminated all insurance administrative costs that currently existed, we'd still be talking tens and trillions of dollars. I mean, you'd still be looking at a price tag in the $30+ trillion over 10 years to the federal government of financing Medicare for All. So it's not just insurance administrative costs that we have to deal with. And if you actually look at the proposals that have been put forward, the biggest savings that they basically attempt to get are not from insurance administrative cost relief, because there's only so much there, but from cutting payments to providers. That's the engine that they rely on to try to contain the extent to which Medicare for All would increase costs. As for the question of why do other countries have lower health costs than we do, that's an important question, and it's a complicated question. I don't think anyone knows the answer to it completely, but we have to be really careful about what we infer from that question. I mean, you could, for example, say, would we have a more efficient federal government if all along we just had a national government instead of a federal government and a bunch of state and local governments around the country? Could we save a lot of money by condensing all the functions into a single national government and not having all this federal system? Well, maybe we could, but we are where we are, and it would still be incredibly cumbersome and difficult and complicated to have the federal government assume all the current functions of state and local governments. So that's just an analogy, but the point is the fact that other countries have lower health costs than ours in no way implies that if we go to a single payer system, then suddenly our costs will suddenly drop down to their levels. I mean, we're still going to be buying our health services from US doctors, US hospitals, our pharmaceutical companies. I mean, and those costs are where they currently are. So who knows how history might have played out differently if we'd done it differently in the past, but that doesn't help us much right now.
Thank you for that. And we want to tell all our participants that we said 1, we're going to go till 1:15. If you leave us, please see that in the chat, we put up a Survey Monkey, which we would really appreciate that you participate in. And leave us with your Q&A. We'll be sending out more information after this webinar. Margarita, I wanted to ask you a question to follow up on that. There are a number of questions in the box about population health and also consumer engagement. How do consumers have a say in what they think are the important things for us to spend our healthcare dollar on? Food, security, other issues, all of which have come up during COVID. Consumers, households pay 28% of our total costs. Where is their entree into the conversation of what they think is the right priority for our spend going forward?
Well, look, the advice I give people is you're a constituent and you should be in touch with your members of Congress, your senators, and your local elected officials, right? And I have to say, advocacy, it is not a recreational sport. Advocacy is serious, and you have to really commit to it, and you have to get other folks in your community to do it. But I think sometimes we get cynical and we believe politicians aren't going to listen to us and they're just going to do what they're going to do. And the prescription drug industry or the health insurance industry or the lobbyists, they will always hold more sway. There's no doubt about it. Lobbyists have a lot of power in Washington, D.C. But if you look at the behavior of politicians, what they care about is votes. right? And so even if you look at the way the presidential debate has played out in, over the past year, we never before have seen politicians like Cory Booker from New Jersey. This is New Jersey, right? This is like Grand Central prescription drug land, repudiating donations from pharma. So that should tell us something, right? That being associated with the prescription drug industry and companies like Johnson & Johnson and Pfizer that have driven the opioid crisis have been prosecuted by attorney generals. Their reputational risk has been huge because of their anti-competitive behavior. We have a moment. Now, my view is people should lobby, and democracy works because people hold their lawmakers accountable, because they participate in elections, because they follow up after the election and they tell their members of Congress what it is that they want. But the other thing we can do is we can look for opportunities and lean in on those opportunities. And I think COVID has created one. The presidential election has created one. And the fact that we have this tremendous energy growing around different healthcare issues that are all interrelated really does create a big opportunity for people right now to be weighing in with your members. Even if your member agrees with you on the issues, oftentimes what it takes is weighing in with a member and asking them to champion an issue, right? Stuff doesn't just happen in Congress, right? I mean, right now in this country, there's widespread support on many issues, on expansion of healthcare, on retirement security, on taxing the rich and corporations. None of those policies will come to pass until legislators reach out to a lawmaker and say, you know what, Senator so-and-so, you need to champion this with your caucus.
Thank you. And Dr. Ho, what are you hearing from patients in terms of engaging with them around their health insurance coverage? We have a lot of questions coming in talking about patients and the complicating factors in terms of getting in to see their doctors, getting access, feeling the risks. What are you hearing from them directly?
Sure. You know, I think that what we hear from patients too is just a lot of concern, frankly, especially in a time period when there is so much to be worried about, least of which would be COVID-19. But one thing that we hear a lot is that if I have insurance, then is my insurance going to pay for this, whatever this may be? And is it going to pay enough? And what's this going to do to my financial bottom line and my ability to provide other needs that I have for myself and for my family? Excuse me. And for those who do not have insurance, then what we hear quite frequently, because we typically don't see these patients a lot of the time until they come to the hospital for something that could have been avoided with earlier care, but has now become much worse and also much more costly in terms of the interventions that are going to be provided. So we hear, how do I get insurance? And I don't have insurance. So is anybody going to be able to take care of me? And what is that going to do to my ability to financially care for myself and my family? But overall, I think that this is a system as it is right now that is very difficult to navigate for many patients, whether or not they have insurance and whether or not that's private insurance. Then it's something that there's a lot of confusion surrounding. And many times physicians are not equipped to help patients with these issues. So I think I'm fortunate here to work for Dartmouth-Hitchcock with our resources for helping patients register for insurance if they don't have insurance, and also talking to them further about that. But that's, of course, not something that's available for everybody in so rural a setting. So I think we just hear a lot of confusion and trepidation with navigating the complicated system, and just a lot of hope for a better system that would be easier to understand and easier to navigate.
Thank you very much. And Chuck, I'm going to ask each one of you, Bob, jump in if you want. We have some great questions, continuing to hear questions about just why is it so much more expensive in the United States? What are we going to see around this conversation going forward? So we've got COVID expenses. We've had huge spending, trillions of dollars spent on COVID relief across the board for hospitals, individuals, unemployment, businesses, tax breaks. What do we see as the future of how this conversation happens going forward? what kind of measurement are we going to use, and how are we going to assess what our priority are going forward around the complicated question of where do we want to spend our healthcare dollars, how much do we want to spend, and what are our priorities? Big question. Jump in anywhere.
I mean, that's a really big set of questions. So I think anyone who pretends to have the answers to all of them probably should be booted off the panel. But I would say, you know, the story of why our healthcare costs are as high as they are is a complicated one. Many different scholars study it, and they disagree as to, you know, how high our health costs really are relative to the quality we receive, and what is the reason for the inefficiencies that we do have. I think there is general agreement that our history has not been good for us in that sense. Basically, we've sort of created the worst of all worlds, in the sense that we've created an enormous tax distortion favoring employer-sponsored insurance relative to other forms of receiving insurance. That has been a driver of receiving compensation in the form of health benefits relative to other forms of wages, other forms of compensation. That has been a driver of healthcare cost inflation. We have a very problematic and confusing amalgam of interactions between government-provided healthcare programs and how the private sector, how they interact with the private sector. And I would also, and this is, I'm probably now going from the general consensus to my personal view. My personal view is that we keep having the wrong conversation. we keep having the wrong conversation about how to make sure that health insurance covers everybody and covers everything, and no one has to pay for anything. But of course, that's not how life is. We're all paying for things. We're just paying for them in incredibly cumbersome, difficult, opaque, and inefficient ways. So just to draw a contrast with something that actually works, like auto insurance. Why does auto insurance work? Well, auto insurance works because we only ask it to do what insurance can do. It insures people against their, potential personal liability in the case of an accident. It insures them against sort of a catastrophic expense. But we don't use it to sort of hide and redistribute the costs of everything we buy for our cars. So if you have to get wiper fluid replaced or whatever, you don't have to get on the horn with the insurance company and figure out whether they cover it and what type of wiper fluid they cover and how much you're going to have to pay out of pocket. And if we tried to do this with our auto expenses, we would have the same confusing, horrible, inefficient, awful, soul-destroying mess that our healthcare system is. And unfortunately, politically, we have not been able to resist the lure of sort of having an endless political discussion about how to promise everybody that health insurance will cover everything without people being charged for it. If we really want to have insurance do what insurance does, we should have it insure people against large expenses. We should provide income support for poor people to handle their healthcare expenses. And we wouldn't try to ask the mechanism of insurance to sort of disguise the cost of healthcare for everybody else. So I think a lot of it is we continually have the wrong conversation and reach the wrong solutions, but that's a personal view. I would say the only thing that I think there's a real consensus on is that our history has been very bad on the issue, and the tax preference for employer-sponsored insurance has been a real problem.
Thank you for that, and a very good perspective in terms of how are we going to prioritize. So I would turn it, MJ, to you, which is this whole question of social determinants of health, that a lot of what we do in our lives is impacts our healthcare that's outside the healthcare system, and that we could really get our handle on cost by addressing those. I think Charles is proposing one sort of type of way to think about that. What's your response to that? How does our healthcare system, or does it at all, address the social determinants of health that are driving a lot of our wellness?
I mean, I think it doesn't. And I would sort of, plus one on, everything that's been said. Look, I think we're not going to get to a serious conversation about the social determinants of health until the conversation goes beyond cost, and we also talk about value, right? Because it's one thing to talk about how much do things cost, and there's many actors in the system that are profiting from the system, but there's also the big issue that when we deploy public resources, we don't always deploy them in a way that serve the interests of public health, with thinking about how we incentivize, certain kinds of treatments, developments, coverage for groups that already have the greatest level of disadvantage because of systemic racism, because of gender discrimination, all kinds of things. And so, one thing that we've seen, especially around social determinants of health, is that there are really clear examples where just having coverage or just having money or just being affluent is not going to solve the problem, right? When we are seeing, for instance, Black women dying in childbirth at much higher rates than white women, you might look at that and say, well, look, structurally, Black people have much less wealth. They are disadvantaged because of the legacy of racism. That's all true. What's more troubling is when you look at the fact that even Black women who have the same indicators as white women, so they're college educated, they're making a commensurate amount of money, but they're still having the same health outcomes as Black women that don't have insurance and don't have a lot of wealth or a lot of resources. Something is clearly wrong. I really think that one of the challenges around this debate, and I would agree, like the politics of the debate creates a lot of challenges. One of the challenges is that it sort of takes up all the space and obscures these other big debates about the fact that coverage and costs are important, but they're not the only things that are important. Because if you are a low-income person living in Little Rock, Arkansas, and you can't get access to food, and you can't get access to clean air, and there's lead paint in your house, and you are under constant stress because of your job, because you're nervous to send your child out down the street to the 7-Eleven, that is going to have an impact on your health. And I think really that conversation has been very much obscured in the healthcare space because we are busy talking about cost and profit. And those things are very important things as well, but they're not the things that are going to solve every single problem. And I know we work with a fair number of experts that would say that coverage is incredibly important, but some of the experts we work with say it's not even the most important thing when you're talking about underserved populations, indigenous populations, people of color in some of these places where they really don't have access to any of the basics.
Okay, and I'm going to ask Dr. Ho one question, and then each of you to say some final words, and then we'll wrap up. But Dr. Ho, there are a lot of questions that we are getting about just, okay, that's all fine, very complicated, priorities, revenues, et cetera. I know we spend a lot on healthcare. We spend more than other places. At the end of the day, if we don't do something like healthcare for all, where we have more control, we will never get our arms around why an MRI down the street can be $700 or $5,400. And no one seems to be watching the store to take away that incredibly seemingly random and disparate price variation that impacts our healthcare system and the access. So how do we look at this when you're responding to a patient or a consumer saying, that just doesn't seem rational? How will we get there if we don't jump in together to solve that problem? We haven't seemed to solve it to date.
Sure, and unfortunately, I think the answer is that if we don't change the way that we do things, we are never going to get to that satisfactory endpoint with a positive outcome, where unwarranted variations in both utilization and prices of care are eliminated. I think it's very important to think about these unwarranted variations because this happens both in terms of utilization of healthcare and then also in terms of price. And certainly the price of care has become more transparent within the past few years. But again, many of our patients and also many of the people that work in hospitals do not have easy access to these numbers. And for that reason, then these disparities are going to keep increasing, to say nothing of the disparities that our patients face in terms of their outcomes when they come to see the doctor. So I think it's important to note that doing nothing at this point is not an option if we want to get to a positive outcome where everybody has a good experience of care as well as a satisfactory quality of care. than a satisfactory health outcome as well.
Thank you, Dr. Ho. And I'm going to turn to each one of you and ask you to please give us just a little heads up as to where you think this conversation is going to go in the next year, because we are going to challenge all of our participants to bring this conversation to the places where they are talking, bring people with different opinions together so we can continue this conversation out in the community. Where do you think this is going? I'm going to start in reverse order. MJ, what do you think we're going to be talking about in a year?
Well, listen, I think that COVID really is going to transform the conversation, and because of a number of different things, but not the least of which is the inertia in our politics, people are going to want to go back to the familiar conversation about cost and is it Medicare for all versus public option, this, that, and the other. And I think really we have to resist that, right? We have to use the COVID opportunity to have a larger interrogation of the healthcare debate that is more about public health and how we use public resources. And I'll just give one example, right? We are watching billions and billions of dollars go into the development of a vaccine. Every single time I speak on a panel about prescription drugs, people ask me the same question, which is, isn't it true that if we lower the cost of prescription drugs, we won't have as much innovation from the prescription drug companies? It's a fantastic myth. We don't have that much innovation from the prescription drug companies now. It's largely public dollars that are funding innovation. But that myth has been perpetuated really effectively, and largely we are complicit in the myth because we are not posing a different set of questions, right? And so if we're going to deploy public money, whether it's for coverage, whether it's for the development of prescription drugs, whether it is for really trying to tackle the social determinants of health and disparities in the healthcare system, then we should also be trying to have a conversation on different terms that speak to bigger values and that really, talk about what's our role as taxpayers and consumers, and what power and leverage do we have to make a serious set of demands? Because largely this conversation has sort of played out among politicians and pundits in a way that when you talk to regular people, doesn't resonate. Before I came to Washington, I spent 15 years knocking on doors in very poor places, and the projects in Louisiana and Missouri and Arkansas. Many, many, many people said to me, MJ, I really need health care and I would do anything to get coverage. But nobody said to me, but only if it's not for profit single payer coverage. They just wanted coverage. Like regular people want solutions and they want coverage. And so I think, to me, all questions lead back to organizing and to having that different kind of conversation that gets us to a different kind of consensus.
Thank you. Dr. Blahhaus.
Oh, wow. Okay. I'm going to say, I'm at the risk of inadvertently making news here, but I'll just call it a prediction. I'm sure the news you've been watching, like the news I've been watching, has been dominated by certain things over the last several weeks. Everything from the COVID crisis to racial disparities to politics and the interactions between the president and Congress, et cetera. I predict that a year from now, some of the issues that are currently lurking below the radar screen, which the press is not paying attention to, are going to leap up and smack us in the face. One of them is a financial crisis facing our current Medicare program that is being exacerbated by the COVID crisis. The COVID crisis is precipitating a recession, economic contraction that is cutting very deeply into Medicare and Social Security's payroll tax revenues. Coming into this year, the Medicare Hospital Insurance Trust Fund only had enough assets in it to cover about 7 months worth of benefit payments. Now, that didn't mean that Medicare was going to become insolvent in 7 months. What that meant was that everything depended on enough tax revenue coming in the door to finance Medicare benefit payments going out the door to keep the system afloat for a few more years. And of course, that is not happening right now as the recession is hitting. And so what is going to happen is that lawmakers, probably the beginning of next year, are going to be confronted with a very dire situation in current Medicare. And they're going to have to make a decision. Either they're going to have to raise Medicare taxes and cut the growth of Medicare benefit payments pretty soon and pretty rapidly, or if there isn't the stomach to do that, they're basically going to have to sort of abandon the current financing model by which Medicare hospital insurance is being operated. And it may, I think there's a reasonable risk. I mean, I hate to say this as a former Medicare trustee, there's a reasonable chance that lawmakers simply may not have the stomach to do what is necessary to keep Medicare hospital insurance solvent, and they may just have to do away with the financing structure that it currently has altogether. That debate is going to jump up and grab us by the throat early next year, and it's going to render, I think, a lot of these more ambitious questions about how do we achieve Medicare for all or more universal coverage, very quixotic in the near term, because we're going to have a near-term Medicare financing crisis that they're going to have to deal with.
Thank you. Great reflections. Dr. Ho.
I would first just like to express gratitude to MJ for talking so much and so in depth about the social determinants of health too, because I think what we're seeing in America and what we've seen really for much of the last century really is that throwing more and more money at healthcare itself is not going to work and is never going to work. And what we're seeing now play out because of COVID is we're seeing everything that we already knew, but we're relearning it again in very devastating ways. And so I think the challenge for healthcare providers and also the medical apparatus over the next year or so is going to be how can we reprioritize our care as well, from ensuring that there's enough money and enough power to continue biomedical research, but then also deal with and adequately address the social and economic factors that affect our patients' healthcare outcomes, because in many ways those are much more important than the care the medical care that our patients receive and that we provide. And so regardless of the overarching context of healthcare and whether or not we have healthcare coverage for all, then for those who work in healthcare, then we need to make sure that we refocus our efforts on being a place that patients can come to not only receive quality medical care, but also address factors of social and economic concern, and then ensure that the care that we provide is safe and above all equitable.
Thank you so much to all of you. What I'm hearing is we need to pay attention not to do exactly what we were doing before. We really have to look to the future, take advantage of what we're learning, and really get our house in order. So thank you so much to our panelists for your incredibly insightful words and for sharing, especially to our partners, the Medical Society and Granite State Progress, and our generous sponsors, the Peterson Foundation and the Endowment for Health. To all of you who helped us out, thank you very much. Wonderful time with all of you. Everyone, please respond to the survey. We'll take your questions. We'll provide you the PowerPoint. We have links for you to find out more. This conversation needs to continue, so please take it out into the community, and we'll be here to help support that effort. Thanks so much, everybody.